وين share ولكم في share طيب let us go to share. ها؟ share screen. Screen share. Okay. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. الأخ فارس، الدكتور فارس، كيف حالكم؟ مساء الخيرات. We are going to discuss chest X-ray in cardiology today or this evening, and have a nice day or a weekend. So this is the first slide is about a 70-year-old lady with a normal chest X-ray. This is like a normal findings for a 70-year-old lady with a normal chest X-ray. And again, this is another chest X-ray, normal, of a 55-year-old lady who was referred to us to cardiology for cardiac clearance, and her chest X-ray is also considered to be within normal limits. And also her ECG is normal, typically normal, because lead 1 and lead 2 are pointing upwards, and V1, V2, V3 are pointing downwards, V4, V5, and V6 are pointing upwards. Let us take an abnormal finding or an abnormal scenario about a 21-year-old patient with atypical chest pain. And this is the ECG to start with before we see her or his X-ray. So the ECG is showing sinus tachycardia, and probably there is more additional findings. Maybe there is a small Q waves in lead 3, and there is also T wave inversion in lead 3. And again, this is her X-ray after the tachycardia was settled down. And this is her chest X-ray. Obviously looks okay, apart from this abnormal shadow on the right lower base of the right lung. So when we did a CT scan, the CT scan showed a wedge pulmonary infarction, and this is called Hampton sign. So this is Hampton sign of pulmonary embolism. We have three important X-ray or imaging signs of pulmonary embolism. This is Hampton sign, which is a wedge pulmonary infarction. The other sign is Westermarck sign, in which the lung will be oligemic due to the pulmonary embolism and pulmonary infarction. And the third sign will be Bala sign, in which the proximal part of the pulmonary trunk will be prominent. So this is an X-ray of a patient with pulmonary embolism. Let us take another X-ray finding of a gentleman who has shortness of breath, chronic shortness of breath, and the CT scan findings of honeycomb appearance of or pulmonary fibrosis. We can appreciate that there is pulmonary fibrosis. Let us take an example of a 35-year-old male who survived cardiac arrest, and this is his ECG. And this is his ECG after the cardiac arrest, which showed clearly he has got ventricular tachycardia. And the ECG further give us curved ST elevation in V1 and V2 for the same patient who's 35 who survived cardiac arrest, and this is consistent with Brugada syndrome type 1. Of course, because of his Brugada syndrome and because of the cardiac arrest, he should get a defibrillator. And this is the X-ray of a defibrillator. When you see it on the X-ray film, there is a generator box, there is the lead, but when it is an ICD, you will get this cover of the lead, which you normally don't see on a pacemaker. So this is why this device is an ICD or a defibrillator rather than a pacemaker. If it was a pacemaker, you will only see the thin wire without any cover or without the coil around the lead. And the tip of the pacemaker or the tip of the defibrillator usually will be inserted into the right ventricle, across the tricuspid valve into the right ventricle. So the patient received an ICD after he was successfully resuscitated from his ventricular tachycardia secondary to Brugada syndrome, and he had a defibrillator. Let us take another case of a 90-year-old male who had CABG, open heart surgery in 2004, and he was admitted for an ICD in 2008 because his LV function is poor, and eventually he developed exertional syncope and repeated pulmonary edema. So this is his X-ray finding of a patient who underwent prior CABG, and he had a prior ICD. You can appreciate that this is an ICD because it has a thick lead, and this is the pulmonary edema. There is bilateral fluffy shadows. These changes nowadays will be considered as COVID pneumonia, COVID-19 pneumonia. And the patient was found to have severe aortic stenosis. After he was given IV diuresis, you can see that his lung fields appear to be cleared. The ICD is cleared, and you can see there is a mesh work in the aortic area. This is the TAVI prosthesis, and this patient developed severe aortic stenosis several years after his CABG. He's 90 years old, so he could eventually develop degenerative calcific aortic stenosis. And nowadays, the management in our cardiac center or elsewhere is by putting a TAVI prosthesis through the catheter. And this patient underwent catheter procedure by TAVI. And this gentleman, who's 90 years old, he had prior coronary artery bypass graft surgery in 2004, and he underwent a defibrillator in 2008, and he underwent a TAVI prosthesis in 2012. This patient described to us how medicine has evolved or has advanced in the field of helping the patient. So this patient underwent 3 procedures. The first procedure was coronary artery bypass. Then he underwent a defibrillator, and we said this is a defibrillator because of the thick lead. And in the middle, you can appreciate there is a mesh work of the TAVI prosthesis. And this is a closer look, a zoomed view at the center of the chest, where you can find the sternotomy wire, and this like an inverted bottle sign of a TAVI prosthesis. Nowadays, TAVI is the mainstay of treatment for any severe aortic stenosis, but sometimes there are contraindications for TAVI, including bicuspid aortic valve, or if the access to the femoral arteries or to the aorta is not accessible for the TAVI procedure. The TAVI usually is done from a femoral approach in 90% of cases. In only 10% of cases, it is done by a transapical approach, but in that instance, needs the surgeon to intervene. TAVI is now considered, maybe in the last 10 years, is one of the most exciting advancements in cardiology. And the first procedure was done in year 2003 or 2002. And nowadays it has been the standard for all elderly people or even younger people with any severe aortic stenosis. Cardiac CT is important from the femoral artery until the heart to do a CT scan to see the diameter of the femoral artery, iliac artery, and the aorta, because the valve will be introduced from the femoral artery, and the femoral artery diameter should be at least 6 millimeter or 7 millimeter, and the aorta should not be calcified and not tortuous to allow the introduction of the valve. Let us take another example of a 30-year-old lady with myasthenia gravis and hypertension, and she was seen in our cardiac center, and she underwent actually a cardiac procedure. And her cardiac procedure was done for her coarctation of the aorta. So this is similar to the TAVI, but it is not over the vertebral column. It is parallel to the vertebral column, and this is the aorta. So there was a coarctation of the aorta, and this is the stent of the aorta at the level of the coarctation, which is distal to the left subclavian artery. And this is the procedure of the coarctation of the aorta. This is the catheter, and this is the web constriction of the coarctation of the aorta, and this is when the stent has been inflated. And these are different types of stent we use for coarctation of the aorta. Coarctation of the aorta can be treated by stenting or by surgery. Stenting, of course, is equally easier. Stenting or surgery will not actually obviate the risk of dissection. Still, dissection can occur. And this is the aorta, and this is the constriction or web-like of the quark. distal to the left subclavian artery. This is the catheter introduced, and then a stent will be inflated. So aortic coarctation is found up to 10% of all congenital cardiac disease, and usually the patient can present with upper body hypertension and fatigability. The classic radiographic signs could include figure of 3 or reverse figure of 3 and rib notching. Rib notching will not develop early, it will develop after 10 years at least because of the collateral enlargement, and there will be rib notching on the inferior surface of the rib. This is the figure of 3 due to coarctation on this X-ray. What are the association of coarctation of the aorta? It could be associated with bicuspid aortic valve. 50% of coarctation of the aorta will be associated with bicuspid aortic valve. Turner syndrome, Noonan syndrome are also other associations. Let us take another example of a 13-year-old patient who had a cardiac procedure in our center. We see like a coil in the region of the aorta and pulmonary artery, and near the tracheal bifurcation. And this coil is like, this is the coil we usually put in catheter to close the patent ductus arteriosus if it is not closed. So this is a BDA closure coil we put usually. And this is another photo of a BDA closure coil we are getting. So spontaneous closure of the patent ductus arteriosus. So this is patent ductus arteriosus. After some years of observation, if it didn't close by itself, we put this coil to close it. And we have these X-ray findings of a coil closure of the BDA. BDA spontaneous closure is common. And sometimes if there is significant respiratory distress, treatment by intravenous endomethacin is frequently effective in closing a patent ductus arteriosus if it is administered in the first 2 weeks of life. BDA closure by coil is recommended for patients with moderate to large BDA with symptoms of significant left to right shunt. Let us take another example of a 25-year-old staff with cardiac history. And this is the X-ray. You can see that there is like a button shape in the middle of the X-ray. If you can see like a button, 2 dots are seen on this X-ray. And this is a patient, his ECG is showing right bundle branch block. Commonly congenital heart disease. Many congenital heart disease are associated with right bundle branch block. So this is a device closure for a patent either ASD. We put this device to close the patent ASD. And sometimes there is association of right bundle branch block, and you can see that there is also left axis deviation. This has been the presentation for today. I thank you very much for joining me for X-ray findings in cardiology. For those who comes late, I will go to the first case. It is interesting actually to show the gentleman who underwent. So this is a 90 years old from our cardiac center in National Guard Hospital. He's 90 years old who underwent 3 cardiac procedures. He underwent coronary artery bypass graft surgery in 2004, and after a few years he received an ICD because his LV function was less than 30%. But then he started to develop pulmonary edema, and we found that he has developed a atherosclerotic calcific degenerative aortic stenosis, for which he received the TAVI prosthesis. And this gentleman explained for us how medicine or cardiology has advanced. It is believed now that TAVI prosthesis is considered one of the best advances in cardiology over the last 10 years, because it allows so many people, elderly, to receive the TAVI prosthesis for their significant aortic stenosis without the need for surgery. And this is a defibrillator. We said it is a defibrillator because it has a thick coil, not a thin coil. And this is the sternotomy wires. And thank you very much. And this is the TAVI prosthesis at a closer look. Thank you very much for your joining me. And I will try to put this presentation on YouTube. Thank you very much.
Thank you very much, Dr. Ihab.
Thank you very much. بارك الله فيكم.
الله يجزاك خير.
شكرا.